Hello, my name is Alqasim Elnaggar, and I'm excited to present our quality improvement project, determining efficiency scores with the Interventional Pain Assessment Detroit scale. This work was done under the mentorship of Dr. Rahul Vaidya with support from the Orthopedics Department at the Detroit Medical Center. The Interventional Pain Assessment Detroit, or IPAD, is a novel method of evaluating pain. It simplifies pain into three actionable categories: no pain given a score of 0, tolerable pain given a score of 1, and intolerable pain given a score of 2. Unlike traditional numeric pain scores, which can be ambiguous and hard to act on, the iPad gives clinicians a clear functional target. It reframes pain as something we can either manage effectively or not, based on patient-reported experience. This is particularly important in postoperative care, where effective pain control is directly tied to recovery speed, satisfaction scores, and even complication rates. By using the scale, our goal is to determine what constitutes an acceptable efficiency score, the percentage of patients reporting no or tolerable pain, and use that to optimize clinical protocols. We conducted an IRB-approved prospective study of 527 patients at an academic joint replacement practice. All post-operative patients completed the iPad questionnaire, and we also recorded their daily morphine milligram equivalent, or MME, intake. Efficiency scores were calculated by determining the percentage of patients who reported either no pain or tolerable pain after surgery. To analyze these scores and create performance benchmarks, we used SPSS to perform hierarchical clustering and k-means clustral analysis. This allowed us to group providers' pain protocols performance into clearly defined efficiency tiers. The intervention's core aim was to define actionable thresholds so clinicians could know whether their current pain protocols were performing poorly, acceptably, or excellently. It also allows clinicians to compare their protocols with other clinicians to know if they can make improvements. The results were clear and impactful. K-means clustering divided the efficiency scores into three tiers. Poor scores were those below 63%. Acceptable scores were those from 63% to 85%, and excellent scores were above 85%, meaning 85% of the patients or more had no pain or tolerable pain protocols. This three-tiered system provides an easy-to-use framework for evaluating pain management quality. We also stratified the results by MME dosage to fine-tune the benchmarks. For example, patients taking less than 30 MMEs had an acceptable efficiency range of 60 to 78%, with scores above 78% considered excellent. For patients on higher doses of MMEs, like 70 MMEs or more, the acceptable range narrowed slightly to 59 to 75%. These ranges show that acceptable performance varies with opioid use, and our framework gives providers a data-driven way to calibrate their pain protocols to different patient needs. In conclusion, this project delivers a practical classification system for postoperative pain management using the iPad scale. Less than 63% means your protocols likely need improvement. 63 to 85% of patients reporting no pain or tolerable pain is an acceptable benchmark, while above 85% is excellent and should be aimed for. Because the iPad scale is still a novel tool, this classification system marks an important step towards standardizing its use. Future studies should explore how external factors like patient demographics or comorbidities impact their scores, and quality improvement cycles can now focus on pushing more patients into the good or excellent efficiency range. To wrap up, here are a few questions I anticipated a judge asking and my answers. So why should we replace traditional pain scales? The iPad scale simplifies assessment and it avoids the subjectivity of a 0 to 10 pain scale and guides clear clinical action. Intolerable pain requires immediate action, while tolerable or no pain indicates an adequate pain control. How generalizable are these results? This study was conducted in joint replacement patients, so generalization should be done cautiously. However, the model is adaptable and should be tested in other surgical populations. So, could patient-reported pain still be biased? Yes. All subjective measures have limitations, but by reducing pain into functional categories, iPad minimizes variability and focuses on whether pain is manageable rather than how painful it feels, and gives providers a benchmark to achieve for. What's the biggest takeaway? Providers now have an evidence-based actionable benchmark with a DEPA efficiency score below 63% as a call for protocol revision. Scores above 85% should be strived for and represent excellent performance, and this guides providers as to how they can manage a patient's pain postoperatively. Thank you for your time, and I'd like to acknowledge my co-authors, Jack Mao, David Allen, Lauren Boggs, as well as our mentor, Dr. Rahul Vaidya. We hope this tool helps set new standards for evaluating pain management in clinical care down the line. Thank you.